Good morning / afternoon, happy midday. Thank you everybody for coming today. It's a pleasure to see so many people here. I'm going to go ahead and get our program started. Thank you for coming to our online event, Managing Speech and Swallowing Issues with Parkinson's. Today's program is brought to you by Parkinson's Community Los Angeles, and today you have me, Julia Nicholls, speaking to you about swallowing issues in Parkinson's. I am a board member of PCLA, and we are a nonprofit that supports families living with Parkinson's through free education programs like this one, online and in-person support groups, social events, and more. Today's conversation is brought to you by our generous sponsors, Abbott, Acadia, and Boston Scientific, and by important donations from people just like you in our Parkinson's community. If you appreciate our work, please consider making a donation at pcla.org. Your donation is 100% tax deductible, so thank you in advance. We really do rely on your generosity to help us continue this important work. Okay. I will just give you a little bit of information about me. I received my master's degree in communication disorders from California State University, Los Angeles. I've worked as a speech language pathologist in outpatient neurological rehab at Cedars-Sinai since 2005. I've worked as a per diem speech therapist at California Rehab Institute. I am currently a clinical educator at California State University, where I work with students in the speech pathology program. And my areas of interest are Parkinson's disease, working with people post-stroke and brain injury. I also work at Santa Monica College, where I run some groups for people with brain injuries. So I think we are going to go ahead and get started. I'm going to bring up my slides. Okay, here we go. We'll be talking today about swallowing and choking that sometimes occurs when people have Parkinson's. I'm going to try and do my best to provide you with enough information, but not too much information. And I will certainly make sure I save time for questions at the end. Briefly, I'm just going to remind us what normal swallowing looks like. So really, the big picture of normal swallowing is it is about getting liquids and solids into the stomach, so through the mouth, down the esophagus, and into the stomach. And we want to bypass anything going into the airway. It's a process that takes about 30 muscles, 6 pairs of cranial nerves, and multiple complex circuits in the brainstem and other areas of the brain. An important thing about a normal swallow is that we have to coordinate breathing and swallowing. There is some shared anatomy here, the throat. We have to be able to shift from breathing to swallowing. And sometimes the issues are with this coordination of breathing and swallowing. Let's define dysphagia. Dysphagia is a swallowing disorder. So as we talk in this presentation about dysphagia, know that we may be talking about a variety of different impairments or challenges. So dysphagia can include difficulty chewing. It can include difficulty getting the food in the mouth all together so that it is ready to swallow. It can include drooling. It can include difficulty initiating a swallow. It can include some difficulties with just managing where the food and liquid goes. Some people may inhale the food or liquid, which is known as aspiration, and we'll be talking about that. It could include choking. It could include food or pills getting stuck, and it can also include the feeling of food or liquid being left in the throat after swallowing. So as we talk about dysphagia, know that it doesn't always mean choking, or it doesn't always mean something disastrous. For you, it may be, I have difficulties managing saliva, or you know what, my pills get stuck. This still is included in this idea of dysphagia. This is an X-ray of somebody when they swallow. And what we typically see with a normal swallow is that the food and liquid comes from the mouth and it zooms down the back, which is the esophagus. What we see in a disordered swallow is that that food and liquid may go down the trachea. And the trachea is the pipe at the front. It's our airway, our windpipe. And that is what we are talking about when we talk about aspiration. It is when somebody inhales food or liquids. How do you know if you have dysphagia? How do you know if you have a problem? We have a questionnaire. When I say we, I'm talking about speech language pathologists. We are the people that you typically see when you have changes to your swallowing. And there are 10 questions that we typically ask our patients to help them figure out if they have a swallowing problem. I'm not going to read this all out for you, but this is in the presentation and I will have all the slides available for you so you can give yourself this little questionnaire if you like. You're going to rate different aspects of swallowing and you're going to rate how bad of a problem you think it is. If we do have some extra time at the end, I'll come back to this. But just know this is a starting point for you to figure out if you think maybe you've got some challenges in your swallowing. If you score 3 or more, that is an indication that you may have a change in your swallowing. You may have dysphagia, because typically a person who does not have dysphagia would score 0. So anything really above a 3 is an indication. Let's look at some of the numbers related to Parkinson's. About 80% of patients with Parkinson's can develop dysphagia. Now, again, I want to bring us back to that big description of what dysphagia is. It doesn't mean necessarily that you will choke or that you will have severe difficulties. It includes that you may have difficulties managing saliva. It may include that sometimes after you swallow, food sticks in your throat. That is dysphagia. It is prevalent in about 10% of patients in the first year after diagnosis. So at the beginning, most people don't have any problems with dysphagia, but it may occur a little bit later on in your disease. Interestingly, there is a greater risk of having dysphagia if you have some impairments in your sleep-wake cycle. So if you're somebody who has some sleep issues and you find that you have daytime sleepiness because of these sleep issues, you may be more at risk of having dysphagia. Aspiration, which is inhaling food or liquid or saliva, is present in approximately half of people who have Parkinson's. We're going to talk about, do I have to worry if I have aspiration? I mean, maybe and maybe not. So we do know that it occurs, and again, in about half the people with Parkinson's. It occurs in the general population too. Everybody aspirates. The question is, how significant is that? Does that mean I'm going to get pneumonia? In people with Parkinson's, we also see silent aspiration, and that is when there is no cough. So it's not always easy to tell if somebody has had an aspiration event if they don't cough. Another finding from the research is that people who have difficulty initiating that swallow, if you have difficulty sometimes getting that swallow going, it feels like food sits in the back of my throat and I just can't get that swallowing going. That is a greater predictor of aspiration. You may be more at risk. What are the consequences of having dysphagia? For some people, we see a decreased quality of life. It is not so fun to go out to eat in your favorite restaurant if you are coughing when you eat, or if food gets stuck when you eat, or you just don't enjoy food so much. So we do know that there is a quality of life issue. People may experience decreased physical health. If you're having difficulties swallowing, people sometimes end up having reduced calorie intake. You just don't eat as much. It takes too long. You have to chew your foods up. We know that with Parkinson's, people often have a change in their sense of smell, a change in their sense of taste. So food just may not feel as exciting as it did before, and therefore you just don't eat as much. When you have decreased calories, that affects your overall physical health. People can be at risk of malnutrition and dehydration. Sometimes it is recommended for people that they need to change the types of foods and liquids that they drink. And I'm sure that some of you have had recommendations or know people that have had recommendations, for example, to thicken your liquids. So instead of drinking a glass of water, you drink thick liquids. People don't like it often. They end up getting dehydrated because they don't enjoy those thick liquids. Or somebody who has had the recommendation of all your food needs to be pureed, or it all needs to be ground up or minced. It can, again, just lead to people not eating as much, and they can get malnourished. So we want to really pay attention to people's intake of food and liquid. If you're having difficulties swallowing, sometimes that leads to a further decline in swallowing because you're just not swallowing as well, as strongly as you typically were. And so again, we want to be really mindful of someone who has dysphagia, that we really look at maintaining a good swallow. And one consequence of dysphagia is aspiration. You may aspirate or have food or liquid go into your lungs. The big question, does aspiration equal pneumonia? The answer to that is it depends. And there are a few different factors that it depends on. One question that we are asking is, what is the person aspirating? That makes a difference. Something that is thicker, some liquid that maybe has more chemicals or acids in it, are going to be more harmful to the tissues of the lungs than something like a glass of water. So if you drink a glass of water and you cough and splutter, it's not pleasant, but generally that water is not particularly dangerous to the tissues of the lungs. Now, it does depend on how much you aspirate and how frequently this occurs. But if we think about something like orange juice is not going to be so friendly to your lungs because it's acidic. If you have the unfortunate experience of having reflux or vomiting and you aspirate that, that is not good for the lungs. It's very acidic. Anything that has stomach acid in it is very difficult for your lungs to manage. So the question, am I going to get pneumonia? It may depend what it is that you inhaled. Another question is, what is the body's response? Our bodies have a good way to respond to aspiration. We have a cough reflex. Something goes down the wrong way, you cough, and you expel what it is that went down the wrong way. That is a good body response. So even though, again, it may feel unpleasant in the moment, your body is doing what it is supposed to do. We also have very specialized white blood cells that digest potential infections. So if you did inhale something down into your lungs, the white blood cells are there to try and help manage that infection. So those are two big questions that we ask when we're thinking about, does aspiration mean I'm going to get pneumonia? And then we also have some other risk factors that help us to figure out who is at risk of getting pneumonia from aspiration and who is less at risk. These are general risk factors. These are not risk factors that are particular to people with Parkinson's. This is for the population at large. But as we look at this list, we can see that there are some risk factors that are outside of your control, and there are some risk factors that you may have some control over. People who are dependent on others for oral hygiene. That means if you need somebody to brush your teeth for you, that's a risk factor for pneumonia. If you have poor oral hygiene, if you have decayed teeth, you are more at risk of pneumonia. And that is because if you are to take that sip of water and it goes down the wrong way and you cough and splutter a little bit, if you have decayed teeth or you have a lot of oral bacteria, that goes down into your lungs. So this is a risk factor that you can work on. You can be really good about brushing your teeth, flossing, seeing the dentist, making sure that your mouth is not a place where you can get oral bacteria. Another risk factor is suctioning. Anyone who needs to use suctioning to manage saliva. People who are dependent for feeding. That means, again, somebody who is feeding you because you're not able to feed yourself. People who are tube fed. If you have a tube going into your stomach that is feeding you, you are more at risk of pneumonia. People who have decreased immune function. If you have multiple medical comorbidities, that means that you have multiple medical issues. Aside from the primary, for us, we're talking about Parkinson's. Again, it's a risk factor. If you have anything impairing your lung function, like COPD or chronic obstructive pulmonary disease, your lungs are already compromised. So if you aspirate, that's going to be harder for your lungs that are already compromised. People who have congestive heart failure. People who have weight loss. If you take a large number of medications, again, some of these you can't help. You cannot help it if you have a lot of medications. You cannot help it if you have congestive heart failure, but we're going to be perhaps more conservative with you. People who smoke. So if you smoke, hopefully that is something that you can say, you know what, I need to take care of this. Physical mobility. People who are bedridden have an increased risk of having pneumonia. So we know that moving is very important. If you have a diagnosis of dysphagia, that in and of itself puts you at a higher risk of having aspiration and therefore pneumonia. People suffering from delirium, people who have urinary tract infections, UTIs, people who are on a mechanically altered diet. So if you have had changes to your diet, you're eating soft foods or pureed foods. And that's because typically there's an underlying reason why you need to have your foods altered. And then age. So again, just to reiterate, these are general risk factors for the population at large. Everybody aspirates, and what we're trying to figure out is who is going to get aspiration pneumonia. So the more of these risk factors that you have, the higher the risk is that you could get pneumonia. What are some signs? How do you know if you have aspiration pneumonia? People can suffer chest pain. You may cough up phlegm, and that phlegm is dark, it smells bad, it's dark green. A lot of fatigue, more than you normally feel. If you get a fever, if you are experiencing shortness of breath, if you hear wheezing, if there is a bad odor, that is an indication that there may be something colonizing in your lungs. Excessive sweating, increased difficulty swallowing, and confusion. You'll see I put a chest x-ray in here. The chest x-ray on the left is clear lungs, and on the right, we can see this is what aspiration pneumonia looks like. You can see all these cloudy patches right here. This is a chest x-ray of the same person from one day to the next. The person aspirated, and then you could see the aspiration on the chest x-ray. What do you do if you get aspiration pneumonia? The first thing is that you definitely need confirmation that it is aspiration pneumonia. It can be hard to diagnose and is sometimes misdiagnosed. So you want to make sure that it is actually pneumonia from aspirating. You will need to have a chest x-ray done and consult with your medical team to get that diagnosis. Typically, people are prescribed antibiotics, which work very well. When you have Parkinson's, you obviously have to make sure that the antibiotics that you are prescribed do not interfere or have any interactions with your Parkinson's medication. You will really benefit from having an assessment of your swallowing. If you got aspiration pneumonia, we need to figure out why. What happened? What is going on with your anatomy that has caused you to aspirate and for that aspiration to turn into pneumonia? And we really can't tell unless we can do one of those moving x-rays. And some of you have probably had one of those done. You get to eat and drink different consistencies of liquids and solids, and they have barium, that white kind of sticky paste in them. And then we can see what happens. What is your tongue doing? What is your throat doing? Is your esophagus working? Some people may require a bronchoscopy if they have a foreign body. So imagine you have aspirated or inhaled a chunk of steak. You may have to have a bronchoscopy to have that piece of steak taken out and removed from your lungs. If we look at Parkinson's in particular, we see that there are frequently some dysfunctions in the respiratory system. And if I just take us back again to the beginning of the presentation, where I mentioned that we have to be able to coordinate breathing and swallowing. So for somebody who has got some changes in their respiratory system, you may have some challenges with that coordination. I'm not necessarily going to read the whole list of dysfunctions that somebody may experience, but a few that I want to just highlight. Coughing or an impairment in coughing. That's important. If you have a change in your ability to cough, that can affect your ability to expel something that went down the wrong way. People who experience shortness of breath. If you're taking a lot of breaths, and now you've got to chew your food up, you've got to swallow, and you've got to manage that breath, you can see that sometimes people have difficulty and they're inhaling when they're trying to swallow, and you inhale a piece of meat, you inhale that sip of water. So shortness of breath, something to pay attention to. If you've had changes in your voice, a soft voice, it's called hypophonia. That means your vocal cords may not be working quite as well as they could be. And your vocal cords are very important because they sit on top of your airway and they help protect your airway. If you have sleep apnea, and again, that daytime sleepiness, that is also a predictor of a risk of aspiration. Respiratory function and Parkinson's. So I mentioned that people may have some change in how their swallowing and their breathing are coordinated. There's a particular way that people breathe, and we have to be able to expand our rib cage. We have to be able to contract the diaphragm. Here's our rib cage, here's our diaphragm. And so as the person breathes, the muscles help us to expand the rib cage, contract the diaphragm, the lungs fill with air. In Parkinson's, people may experience some lack of synchronization in the contraction of the muscles, which then means that your breathing pattern may be a little discoordinated. We sometimes see something called paradoxical breathing. And what that means is that typically when you take a big inhale, your lungs expand, your belly sticks out. In Parkinson's, sometimes when people take an inhale, their stomach goes in, it contracts. And that's the opposite of what should be happening. When you take a big breath in, and if anyone wants to try this with me, put a hand on your chest, put a hand on your belly. Take a big breath in. What you want to feel is movement of your hand on your chest and movement of the hand on your belly. and the belly hand should be sticking out because your diaphragm needs to contract and move out of the way so that the lungs can expand. If you feel like when I take that big breath in, my belly goes in, that may be that paradoxical breathing, that your belly should be sticking out, expanding to allow more room in your lungs. And again, we've got to coordinate the breath and the swallow, and that can be a reason. So, Alan, to answer the question, what do we do? We've got to also be thinking about where the issue might be. And so for people who are attending today, you may have different issues, and I'll try to cover some of the main ones. The cough. What is a cough? We probably do all know this, but just to be really clear about it, it is a defensive respiratory event. So what do you do when you cough? You have a brief inspiration. So you have a quick inhale, and then you have a forced expiration or a forced exhale against your vocal cords, which are closed. The vocal cords blow open, and that airflow, we've got this nice pressure, that airflow blows through the vocal cords, and that means that you can expel anything, whether it is saliva, that sip of water, that M&M that you just ate and inhaled. You're supposed to have this cough that allows you to really expel something. So if you're with somebody that you know well and you can cough, let's everyone try and do a cough. So as you do a cough, can you feel that brief inspiration? You take a breath in, and then you've got to do that forceful. When you hear that and feel that, that is that air that builds up below the vocal cords, blows the vocal cords open, and then it allows you to cough out whatever is in there. So it's important that you have a strong cough so that you can expel anything that did go into the airway. What does that cough tell us? Well, sorry, I've got another one of those. It depends. A cough is not always an indication that somebody aspirated. Some people cough habitually. You may be somebody who just, you clear your throat a lot. You just tend to cough a lot. So you may habitually clear your throat. Therefore, if you drink something and cough, we can't necessarily say, oh my God, you aspirated, because you may be a cougher. You may be somebody who coughs. Some people have post-nasal drip. Some people have allergies. Some people have reflux. A common indicator of reflux is clearing your throat or coughing. So if you find that you are clearing your throat and coughing, we want to make sure that you know if it's reflux and that gets treated, that if you have postnasal drip, that gets treated. So a cough doesn't necessarily mean aspiration. On the other hand, a lack of cough doesn't always mean that you didn't aspirate, because I mentioned before, you can have silent aspiration. So somebody drinking something, you take that glass and you take a few sips. The fact that you didn't cough doesn't mean that you didn't aspirate. So the only way that we really know is by doing one of those modified barium swallow studies, and we can see where the food and liquid goes. Let's cover choking. What is choking? I've got a picture there. This happens to be of a child with a bead. You know, children choke. Choking, the definition is partial or complete obstruction of the passage of air from the upper airway into the trachea, meaning that you can't get a breath to go from your mouth or nose into your lungs, back and forth. Sometimes small pieces of food may go below the vocal cords. And if we look at the picture right here, the vocal cords in this picture, this object is sitting on top of the vocal cords. Sometimes what happens is that food will go below the vocal cords and it will get stuck somewhere. And you may have partial or complete obstruction. The most common foods to be aspirated are meat and bread and some fruits and vegetables. In particular, steak and hot dogs are culprits for choking and blocking the airway. Your trachea is about the size of your finger. So if you think about your finger, it doesn't have to be a huge piece of something to block your airway. So I don't say this to scare you, but to have you think about it's the size of your finger. So something that gets inhaled down into the airway could cause a problem. What do you do if somebody actually is choking? We know that somebody is choking when they can't make a sound. Sometimes someone's lips might start to turn blue. They may have difficulty coughing. We ask somebody if they are coughing. Can you breathe? You want to see if you can breathe. Can you talk? If the person cannot, then the Heimlich maneuver is required to dislodge that piece of food, that pill, whatever it is that is blocking the airway. All right, so now let's get on to that. How do you reduce the risk of choking? How do you work on this? Well, think about trying to sit upright when you're eating and drinking. If you know there are certain foods that tend to make you cough or choke, think about maybe avoiding them. They tend to be the things that are chewy, the dry, sticky foods. If you find that you get tired because you have to put a lot of work into eating, then maybe make a switch to smaller, more frequent meals so you don't get so tired. So you don't have your breakfast, lunch, and dinner. You have a small breakfast, you have a little brunch, you have a light lunch, you have an afternoon snack, but you get all your calories through smaller meals. Try and practice some mindfulness when you're eating, which is paying attention to your eating. We know that mindfulness is very big these days. You can really use that practice to help you enjoy your food if you can. Focus on what you're eating. Eat slowly, chew well. Consider diet modification if it is acceptable to you, and we have to know if it's appropriate. Now, how do we know if it's appropriate? Does everybody need to cut up their food? No, not necessarily. What we really need to do is to have one of those swallow studies done so that we can see if you're having difficulties with particular types of food. If you are somebody or your loved one is somebody who is at risk of choking, we want to make sure that we are there to supervise. Medication or side effects of medication may impact swallowing. Some medication makes people drowsy. Some medication gives people dry mouth. So if you're experiencing some side effects of your medication, that may be something that you want to talk to your neurologist about to see if that could have an impact in how you're managing food. What about the pills? The pills sometimes get stuck. What do you do about that? Well, if you're having a swallowing assessment done, definitely ask them to try pills with you. There are little barium pills that you can do during that swallow study, and you can see, oh, that pill gets hung up there. This is how we can help you with this. So some ideas for how you can swallow pills more easily. Put your pill in something smooth and slippery. You may take a spoonful of yogurt and hide that pill in the yogurt so that when you take that spoonful of yogurt, you can swallow it down, it slides down. Maybe you're an ice cream lover and it could be in some ice cream. Applesauce is a classic one. In England, people like to cover it in butter sometimes. So if you're a butter lover, think about slathering on some butter. Take one pill at a time. I know this is tedious if you are somebody that has a lot of pills to take, but it's easier to swallow one pill at a time rather than multiple, which can then spread out in your mouth and spread out in your throat. Take the smaller, easiest pills first. There are products that you can buy to coat the pills. I've put a picture on here. This is a gel. It's called Phasix. And you can just see here, hopefully on the spoon, you can put your pill on the spoon, you pump out some of the gel so that when you take that pill off the spoon, it's surrounded by a gel, and that can help you to swallow it. Again, all of these, it is really a good idea to talk to your doctor about this or talk to your speech language pathologist if you are seeing somebody for swallowing and get their input on this. Another really good treatment that we have is EMST, expiratory muscle strength training. It is a little device that you can see in the picture, and I have one right here, that is great for really helping you to train the muscles that you need that can benefit you for speech. We need breath for speech. And they're really important in being able to generate a strong cough. So in this device, there is a little spring, or actually not a little, there's a big tough spring in this device, and you have to generate enough force to be able to break the seal on the valve. So you use this device by putting it in your mouth, you take a big breath in, and you have to do a forceful exhale. And what you can hear, hopefully, is the air shooting out through this device. You have to be able to really squeeze those muscles and push that air out to get the air to break the valve. These devices are about $56. You can actually get them through Medicare. Your doctor or your speech language pathologist can help you get one through Medicare. Again, I would always check that you don't have any contraindications. So somebody who has heart issues, somebody who has high blood pressure, this is not for everybody, but for most people, this is a very good device. So please do make sure that you check with your doctor. If I recommend this to a patient, I always ask the doctor first, is there any reason why your patient cannot use this device? I've put the link in the slides, so you will have that link. I'm just looking to the chat box. I tend to use only the white mouthpiece. That is more like the one on the bottom because it gives a better seal. Absolutely. So there is, I don't know if you can see my picture, there is also a white mouthpiece. Either of them is fine. It really just depends which one you get a better seal with your lips around it. Some people like the open shape of this one, the one that it comes with, but you also get an adapter that you can use as well. And if I put the adapter in, it's the same thing. What you don't want is air leaking out the side. And so for some people, they find that the air leaks out the side. So this is a device that has some good research for people with Parkinson's. Again, I've said this a few times now, get your swallowing assessed if you are concerned. There are exercises that can be done to improve the function of some of your structures. It could be the back of your tongue. It could be the muscles in your throat. It's very difficult to give somebody exercises to do if we don't know what the problem is. So I know it's a little disappointing, especially if you ask, like, what can I do? How can I exercise my muscles? I can't give you all exercises because you have to know really where your problem is. So getting that evaluation is really important, but we can do exercises to strengthen the muscles. Now, again, back to the EMST, this little device. If you don't have any contraindications, this is a good device for everybody because the important thing is about being able to cough, right? Got to be able to expel something. I mentioned diet modifications. You may need to change some of your diet. Maybe you have to cut food into smaller pieces, maybe food that is softer so it doesn't take so much effort and energy to chew, maybe adding in some sauces. Now, I also put here diet modifications may be used to provide resistance training. You have to squeeze your muscles harder for something that is thicker. So sometimes your speech therapist may have you practice swallowing thicker liquids just as an exercise. It's not necessarily that you need to swallow those thick liquids, but when you swallow a thick liquid, think about a smoothie, think about that mocha frappuccino. You have to swallow a little bit harder. You have to exert more muscle strength. So sometimes we use a thicker liquid as exercise. Singing therapy. This is a great way to work on your respiration and the muscles, the respiratory muscles, there is evidence to show that people with Parkinson's who participate in singing therapy had better respiratory control and had better swallowing. So we've got evidence for the singing, we've got evidence for this EMST that not only does it help you to cough, but your muscles are working better. So the muscles that you need to be able to swallow and to be able to cough get really well exercised. Now, those of you that have done speech or voice therapy, there's a couple of great programs out there. Speak Out Therapy is wonderful. Lee Silverman Voice Therapy. We don't have a lot of research. There is very limited research about the effect of voice therapy on swallowing. It is excellent voice therapy. There's just not a lot of research in how it affects swallowing. What we do know is that we do have a lot of reports from people that after completing voice therapy, they feel like their swallowing improves. So we are in that point where we are really waiting for more research to be done to have evidence to say doing the voice therapy improves your swallowing. And we don't really have that yet. What are the causes? Well, you can have aspiration because you have dysphagia related to the structures, the muscles, and the movements that are related to Parkinson's. You may be more at risk if you have an impaired cough reflex. It is harder for you to clear the lungs if you don't have a good, strong cough reflex. If you have decreased mobility, reduced activity can weaken the immune system and again lead to overall poorer lung function. So infections can stick around. And we know that medication, the side effects of some medication can cause drowsiness, and that can increase the risk of having difficulty swallowing. So what are you doing? Let's sum up the treatments. We know that antibiotics are available if you do, unfortunately, get aspiration pneumonia. We know that physical therapy is important. Keep moving. You really want to keep your body moving. The more that you move, the better your lung function is, and the more able you are to move any infections out through your body. We know that in terms of swallowing, there are some exercises that you can do that have to be based on you having that swallow study done. And then we can say, the back of your tongue needs a little bit of work. Let's really try and work on that. We know that the EMST, that little device, has got good research to show that it helps with swallowing and helps with a cough response. We know that you can reduce your risk of having aspiration pneumonia if you really take good care of your teeth, your gums, your tongue, and that you reduce any oral bacteria. Singing. I encourage you to join a singing group. I put some resources on the slides for you. Parkinson Voice Project has a weekly singing group. There is Music Men's Minds. Singing yourself just for your own pleasure, but really knowing that that does a lot for your lungs. And then checking in with your neurologist if you need to have any adjustments to your Parkinson's medications. I'm going to stop talking and see if we've got some questions.
Julia, I'm just going to pop in for a minute and thank you, thank you, thank you. That was so comprehensive and so wonderful. So I know you can't say that to yourself. So I, I just wanted to let you know that I thought it was really an excellent presentation. And I'm sure we will have some comments and questions in the chat now.
Yes, I see Alan asking, what is my contact info? You know what? That will be on the slides that I'm going to share with PCLA, and PCLA will share those with you. So my contact info will be on there. A question from Janet. What is the difference in a speech clinic and going to an otolaryngologist? Excellent question. An otolaryngologist is an ear, nose, and throat doctor who specializes in the throat. Your ear, nose, and throat doctor is excellent in being able to diagnose things like any problems with the movements of your vocal cords. So your otolaryngologist can help figure out if your vocal cords are working properly. You need your vocal cords to work properly because they need to close when you swallow. They're helpful for giving you your voice. An otolaryngologist can help diagnose things like reflux or postnasal drip. Your otolaryngologist will put a little camera up your nose, hangs over the back of your throat, and looks at how your vocal cords are moving. Speech language pathologists work with the otolaryngologist because we are now looking then at swallowing. What happens if we give you food and liquid when you have that camera down your throat? One of the things that we can do is we put that camera down, hanging over your throat. We can give you things to eat and drink, and we can see what happens to it. Does it get stuck somewhere after you swallow? Is there a bunch of food still in your throat? Do we see liquid sitting all around your vocal cords? We can then use that to help you figure out, okay, you need to swallow again, swallow twice, swallow really hard. Look, it all went. Well done. That is a good strategy for you. So going to see a speech therapist, we really focus in on not only the anatomical structures and the function, but how they are impacting swallowing. All right. Other questions that anyone has?
Could you just address for a minute if someone really is diagnosed with aphasia and they are having serious swallowing issues? Can you address the issue of puree, the difference between a soft or pureed food, or even with their liquids, if they were to add nectar thick liquids, perhaps?
Yeah.
What might be helpful on that?
Yeah, absolutely. So if you and your speech therapist, you, your family, your doctor, your speech therapist, thinks that changing your diet is helpful, there are different options. And we look at foods from being a regular consistency, we look at them being chopped up, we look at them being pureed. And what we're really looking at is, why are we doing that? If the person is having difficulty chewing the food up, it may make sense to say, if we chop the food up so that the person doesn't have to chew as much, their swallowing is actually pretty good. Remember, we said that the trachea is the size of your finger. So if somebody is not chewing well, we don't want them to be swallowing and potentially inhaling something that is going to get stuck in the trachea. So making the food soft and chopped can be helpful so that it's smaller pieces. If somebody is experiencing a lot of fatigue and they are not able to get in enough calories because chewing the food takes too much work and they're losing weight, sometimes people are recommended to have purees because there isn't really any chewing involved. You put it in, you push it back, you swallow it. People tend to do a little bit better at swallowing something that is a pureed consistency. Now, on the flip side to that, and Judy, you also mentioned thickening liquids. Thickening liquids happens. We thicken liquids because the thickened liquids move more slowly. When you take a sip of water, I swallow, and in less than half a second, that liquid has gone. If you have a delay in starting the swallow, sometimes what happens is that water goes back before you're even ready to swallow, and then all the coughing goes on. So we may thicken a liquid because then it moves more slowly. The person has time to be able to swallow it. The flip side to thickening liquids, people don't always like them, so they drink less. They get dehydrated, they get a UTI. If you are aspirating thickened liquids, that is actually worse for you than aspirating the thin. So we have to weigh up and be really careful about when we recommend thickened liquids, because if you're aspirating those as well, that's actually worse for you. If somebody is coughing a whole lot when they're drinking water, coughing, 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 that is unpleasant, it is scary, it is tiring. If you thicken the liquids and the person isn't coughing, they just may feel like, I would rather that because I cannot handle all the coughing when I drink the thin liquids. Again, you're trying to weigh up for each person what is going to be most helpful, what is going to make you feel better. Some people don't mind it, some people hate it.
What about carbonated, sparkling waters, things like that? Is that better or worse?
Individual, I would say. It's worse for your teeth to have carbonated beverages. But in terms of for the person, sometimes carbonation, the person has better sensation. They feel it. You may be able to swallow a carbonated beverage better than you can water or milk because you can feel it. The same is true of cold beverages. Some people may do much better with something cold or hot. If
Mm.
you drink something room temperature, it tends to go down the wrong way. So those are definitely some adjustments or trials that you can do. There's a question in the chat box. How about tilting your head down when swallowing? Is that helpful? Again, I'm sorry, it depends. It may be really helpful for some people. It may not be helpful for others. How do we know if it's helpful? The only real way that we know if it's helpful is if we're doing one of those video swallow studies and we can see, here is the person drinking, and oh, we see that liquid going down their airway. Okay, now we ask the person to put their chin down, they swallow, the liquid does not go into their airway. That's really the only way that we know, because if somebody is aspirating silently, I can't tell as a speech pathologist, if I give you a thin liquid and a thickened liquid and you don't cough with either of them, I don't really know what happened to them unless I'm doing that swallow study. So again, it does depend. For some people, taking your pills and putting your chin down is helpful. I mean, obviously, you have the ability to say, this feels better to me than this. So you can certainly try something. And if you take your pills with your chin down and you feel like, man, I don't feel any pills sticking, and normally I do, that may be good enough because you can feel the difference. It's just, it's very difficult because we can't really see where things go. So that was a good question. Another question, is the epiglottis responsible for aspiration pneumonia? Well, the epiglottis is a cartilage that is between the back of the tongue and the throat. So when you swallow, the epiglottis flaps down and it directs the food and liquid down towards the esophagus. Some people have some difficulties with their epiglottis. It doesn't move very well. So food and liquid get stuck behind the epiglottis, or it doesn't protect the airway very well. So it can be responsible for changes in swallowing. The epiglottis, the movement is also connected to the larynx and how the larynx moves. So again, I don't mean to give you a wishy-washy answer, but it depends on you and your anatomy. So for you, that could be a problem. In which case, you want to get a speech pathologist who knows swallowing and can give you some potential exercises that will help you to increase the movement of your larynx up and down. I think we've got time for one more. There is a question. My husband, who has Parkinson's, does not have a problem during the day eating, drinking, taking meds. However, in the morning with his first meds, he has a very hard time swallowing with them and starts to choke. Ugh. I now put them in a piece of muffin and he doesn't have a problem that way, but with water, he can't do it. Any idea why this is happening? It's recent, last 4 months or so. We know that Parkinson's affects automatic movements. It affects walking, it can affect talking, it can affect your voice, and it can affect swallowing. And swallowing is something that we do very automatically. When you pick up a glass and you take a sip, you don't have to think, okay, now muscles, do your job. It's an automatic movement that we have. It gets affected in Parkinson's. So sometimes as Parkinson's progresses, it affects that part of automatic movement. It may be that putting a pill in a piece of muffin is that it gives more sensory information. You now have a chunk of muffin in your mouth and your body feels it. The sensory receptors send the message to the brain. Oh, there's a piece of muffin coming, get swallowing. And maybe just the sensation of the water doesn't take enough information to the brain for your husband to trigger that swallow. I think if it works, you stick with it. You could again try something like that gel, perhaps. Sometimes this is a bit of a moving target, something that works for one period, then starts to not work, and you have to try something else. I have certainly had people say that, yes, they put it in a piece of banana. They maybe put their pill in something else that doesn't really require a whole lot of chewing, because obviously you don't want to be crunching up a pill or breaking a capsule, but something again that your body can sense and then swallow.
Thank you, Julia. I just want to thank you again on behalf of PCLA. It was quite amazing. Really an excellent presentation.
I am very happy to be here today. I will, of course, share my contact information, so anyone who has questions can absolutely hit me up for a question. Thank you, everybody. There's my references if you want to read the research. And I do want to make sure that we thank all of our sponsors who make it possible for us to bring you these presentations. Acadia, Boston Scientific, Abbott, and of course, you. You are the people who keep us going. You know that we are a grassroots organization and we rely on donations. So if you are willing and able and you would like to donate, we gratefully accept donations. You can use the QR codes here. You can go to pcla.org. All the money goes back into producing presentations like this, keeping our website going, having the wonderful support groups that we have. We are here for you as a community. Please join us for our upcoming events. We have dystonia symptoms, manifestations and treatments with Dr. Zenos Mason, who is a great speaker, a wonderful doctor. That is on Friday, June the 21st. Put it in your calendars, 11 to 12. We have got Patrick Lasasso, who is going to be talking about XPD and exercise for Parkinson's on June 27th. Thank you so
all for
much.
attending. It was wonderful. Thank you so much. See you next time.
Thank you, everyone. Goodbye.